see all the new faces. Welcome. And thank you to those of you who have replied and what you wanted to see presented. Many of you have seen me talk on childhood trauma, so I'm just going to cover a piece of that. But from some of the requests, I had developed the impact of trauma, the impact that trauma has on childhood mental health diagnosis. And so that seemed to be somewhat of an interest. And Dr. Swagger is going to be joining me, so hopefully she has some input as well. So I'm going to briefly go over a little bit of trauma, what that looks like on a diagnosis in early childhood, and some tools that I have found to be helpful to me in trying to wean out the difference in the differential diagnosis. So we'll get started. So naturally, you know, the simplest definition for trauma is deeply distressing or disturbing event or events. And we come across a lot of kids who have been exposed to multiple events. And like I've talked about before, especially in early childhood, right? Something traumatic to a child could be anything distressing. And so their perception of danger is not always the same as ours, but that doesn't mean that it's not as intense. And so it is just as intense for little ones who perceive things to be, you know, very dangerous, like the toilet flushing, which could be very dangerous, or, you know, starting a new child care center, which could be very dangerous to them. And so that's when their environment has a huge influence on that. But then there's also very significant events too. And so we'll talk about those different events. Let me just move this. Oops. So traumatic events for children can be very frightening. Like I said, their perception could be very dangerous, and it also poses a threat to them. But when something traumatic poses a threat to them or their entire caregiving system, and so for children, it's not just their own threat, but it's their caregiving system. So many of the times it could be them just witnessing something traumatic occurring to their caregiving system, or even hearing it. So many of the times children will hear stories over and over again, never really seen it or experienced it, but it's very significant to their parents and how their parents might respond, or another caregiver that's involved with them. And if you think about it, you know, I had one mom that was like, I have no clue how they could have heard it. And then when she reflected, she had called and told her sister, she had told her mom, and the child spends time at her mom's because her mom helps her caregive. And so the mom called and told people. So this child was constantly hearing this event, which then becomes vicarious trauma for them. So they're experiencing that trauma through just hearing that event. So trauma experiences can pose very strong emotions in children. And so we know that trauma impacts children on different levels. We know a lot from the ACEs, but it can create some hypervigilance. So very strong emotions, very extreme highs, very extreme lows, some physical reactions as well. So maybe some visceral effects, some belly aches, some headaches, sometimes very fatigued, tired a lot. So, you know, this all can be a result from experiencing trauma. They can start to feel, you know, terror from different situations depending on the traumatic event. They can start to feel like things are helpless to them, right, which can quickly lead into depression. And so, you know, if you think about some of these trauma experiences and the reactions, it's very similar to some diagnoses, right? And so you can quickly see how they can kind of formulate into an algorithm when you're providing a differential diagnosis. So we all know the adverse childhood experiences. We've all heard of that. We've all heard how it impacts children. The ACEs have a huge impact on social emotional development as well as children's cognitive capacity. And so it can create a delay there that can lead to later life difficulties, not only within their social emotional world, but in their physical health as well. And so we've seen how it can lead to later life problems and even an earlier death ultimately. But for children, you know, we know that that exposure kind of puts them into survival mode, and that constant release that places them into survival mode, that fear conditioning, right, that creates stress reactivity, that's all within the brain. And so it has a huge impact on their brain development. Those implicit memories happen early on. And I know we've talked about those on here before, just to quickly revisit, especially for kids who have been exposed to adverse childhood experiences, right? So, you know, a lot of the times parents will say they were too young to know. They're not too young to know, right? They have a physical response. And what happens with the implicit memories is they're firing and wiring together, both positive experiences and negative experiences. And what happens is their body memorizes through the sequence of their brain activity how that happened and what it felt like. And so then when something similar to that happens maybe later on, they might have this physiological response that they don't really understand. And so that's how kids really experience that. And you know, there's a great book by I think it's Van der Kolk, The Body Takes the Score. So yeah, Van der Kolk. So it's called The Body Keeps the Score, and it's a great book about trauma responses and how children's body really takes the toll on that. So overall, this brain activity and development can impact their educational growth. It increases irritability and a lower tolerance threshold for frustration. And so it really can cause dysregulation. And it also increases the stress hormone, which reduces their immune system. And so a lot of the times we see these kids to get very sick a lot. And many of the times that's when pediatricians are like, you know, what else is going on? And so that's why we're seeing some of that physiological response as well as a behavioral response. So the difficult thing is that, you know, we know from the ACEs study that now we're seeing adults who, you know, 61% of adults here that are testing at 4 or more ACEs. The ACEs are, you know, the highest is a 10. And we have adults that are testing at 4 or more, which means there's prevalent adverse experiences there. And that's a risk for our children today, because, you know, then they're at risk for that generational trauma, the repeating of patterns. And so that gives them a risk factor. And so some children will adapt to this, some children won't, some children are at greater risk. So it really depends on the protective factors. So we have those risk factors, we have those protective factors that we've talked about here before. But when you're looking at some of those risk and protective factors, you want to look at the severity of the event. How serious is it? So how serious is the event? Is it a serious event? Were they involved in a tornado? Was there domestic violence? Was it a robbery? How violent was the robbery? Or was it something that we were talking about? Was it the flush of the toilet? Was it that they were in the dark and heard a loud noise? And so how serious was the event for them? The proximity of the event. Again, was the child present? Were they witnessing it? Were they involved in the event? You want to look at, were they hearing the event over and over again? And caregivers' reactions. So caregivers' reactions are really important. Sometimes, you know, shots can be a traumatic event for children. And so a lot of the times parents have a difficult reaction to their children getting shots, and they're like, it's okay. And they're given this like squinty face, right? The children memorize that, right? They memorize because they don't have that cognitive capacity. So they memorize facial expressions and tones of voices to identify when distress is coming. And so if a parent is going, it's going to be okay, they know something distressing is coming next, right? And so if that occurs over and over again, shots can be a difficult thing for them. It can become a traumatic issue. Doesn't mean that they're going to have trauma from it, because they might have other protective factors that overcome that. But caregivers' reactions are really important. And did caregivers believe them? Did they listen to them? Did they hear them? A lot of kids that we work with that have complex trauma, Sometimes, you know, I think of one kid that I have that we work with that has complex trauma, and we've talked about how trauma impacts kids early on, and then each developmental milestone, they gain this cognitive ability to think about it differently, and so they're processing it differently, which is a natural process for releasing that trauma. And so sometimes it's mixed up, sometimes it's not really how it happens, sometimes it's just how they remember it, but however they remember it, they believe it, right? And so it's about what they believe had happened, and it's important for them to feel supported in that and have space to kind of process that and release that. I had one mom that had a really difficult time with that because they were both very detail focused. And so when the child would talk about details that were inaccurate, but really not influential to the treatment itself and had no negative outcomes, mom just wanted to like continue to correct it. And we talked about if the child believes it, then, you know, you have to support that. And so really allowing caregivers to support that and believe children in their process. Prior history of trauma. So a lot of kids who have chronic stress and are exposed to complex trauma, high ACE scores, we know that they're going to be at higher risk. So, you know, depending on that trauma history, as well as the family history of trauma. Is there intergenerational trauma? Is there generational trauma? And so looking at some of that and how it impacts kids. Family and community factors. So cultural community factors. You know, we live in rural Appalachia. There can be traumas within that in itself, but also, you know, within race and ethnicity. So kind of looking at those community factors. So, like I said, there are tons of different traumas. We talked about, you know, perceiving the danger, what that danger kind of looks like for the child, and these are traumatic events and chronic traumatic events that kids can be exposed to. So like physical and sexual abuse, a lot of the times the kids that we see have complex trauma because they were exposed to that a number of times, right? So it wasn't just a one event piece. And so that's where you have to take into consideration when you're looking at the risk and the protective factors. And so what was the severity of the event and the proximity and how long? So looking at that as well. So also, a lot of kids that we work with, they have almost this perfect storm for traumatic outcomes, right? They have childhood trauma. They have a lot of toxic stress situations and adversity that kind of creates this perfect storm for a very complex trauma history. So really looking at that and taking that into consideration when you're looking at the different effects it has on children. So for complex trauma, you're looking at attachment and relationship issues that can happen lifelong. It could be acute or it could be something that is lifelong. The body and the brain, right? We know that trauma has a huge impact on brain and brain structure, especially violence, right? Completely rewires the brain. So we know that from the literature. The body as well. The body takes the toll. The body takes the score. A lot of the times kids will have physical responses. A lot of that is due to that brain restructure, right? Because the autonomic nervous system is connected to that. The autonomic nervous system controls the heart rate, digestion. So all of those things can definitely be impacted by trauma. Their emotional response. So how vigilant are they? A lot of the times with trauma, kids become very hyper vigilant. So when they have an emotional response, it's very intense. There's also disassociation with trauma. A lot of behaviors, especially with early childhood trauma, kids respond in behaviors, and that's how they communicate what's going on. So we have, you know, their cognitive capacity is definitely impacted, and their self-concept, right? So their concept of self. And you know, we talked about that fear conditioning that can occur early on from trauma, and that fear conditioning can lead to that fight, flight, or freeze. And if that continues to go on throughout their life and those fear responses stay activated, it can definitely lead to a negative outcome. You know, as they get older, if they stay in that freeze mode, as children, when they freeze, they just kind of freeze. But if they stay in that freeze mode when they're older, it can lead to more of a negative focus. So that's where they could have that negative self-talk of, oh, you're so stupid, that was such a stupid decision, why would you even, so it just goes into that negative focus that can become a gateway for depression and anxiety. So it can definitely lead to later on complications. But if you look at all of these, right, it can definitely be symptomology and some other algorithms when you're looking at a diagnosis. And so this can all be created from trauma. So there's definitely some overlapping between mental health symptoms and trauma-related symptoms. For example, PTSD, it can present with like dysregulation, behavior concerns, cognition problems, interpersonal functioning issues, and this isn't in the DSM. Yeah, you could probably argue that irritability could be under the behavior concerns, or the hypervigilance can be part of the dysregulation, and problems concentrating could be cognition, but we really don't have these specifics within the DSM and the algorithm when you're looking at diagnosing. So the American Academy of Child and Adolescent Psychiatry has provided this wonderful table for us to kind of look at. And I've referred back to this table a lot, because it's just really helpful to look at it when you're providing a diagnosis and really look at some of the overlapping symptoms, and where, you know, where this symptomology is coming from. It can really help you start to evaluate more of an antecedent, some of the psychosocial background, and help you really identify a true diagnosis or if it's more of the trauma. So this is super helpful. This is right on their website, and it's definitely helped me in the past, and well, present too, continues to help me. I'll probably use this forever until they come up with a new one. So here, the problem is that there's really no child-specific trauma diagnosis. Now, the ACAP did throw around wanting to kind of put in a complex trauma disorder and a developmental trauma disorder. So kind of looking at not only complex trauma, but you know, trauma in development and how that impacts development, but they're not there yet. So there's a lot of back and forth, and there's some literature that supports it. There's some literature that debates it. And so really just kind of looking at more of a child-specific trauma diagnosis could be really helpful. Now, I know I've talked to, well, I don't know, we got a lot of new faces, but some of you I've talked to about the diagnostic criteria for 0 to 5 is what I use, because I specialize in kids 5 and under. And so when I'm looking at early childhood and infant mental health, they do have some more diagnoses that cover some of those trauma areas. However, it's not recognized by insurance companies, and so the diagnostic criteria for 0 to 5 has a crosswalk, and a lot of what that crosswalks to is other specified trauma disorders. So when I'm working with early kids who are experiencing trauma in you know, one area or another, depending on what it is, if it's not PTSD is pretty similar across the board between early childhood and even through adults. They just kind of present it a little bit differently. But if it's not something specific like PTSD, then I usually lean towards more other specified trauma disorder, especially for my infants who are having trouble bonding and attaching, and there's been a significant trauma. So if there's like a medical trauma, that's more of what I'm leaning towards. So treatment for child trauma can also differ from mental health. The child trauma treatment really focuses on the context, like what's going on, the safety and support that's involved. And so we're really focusing on some of the strengths so that we can increase those protective factors. They address symptoms more as the content instead of the process, right? And so the process is more of this underlying issue that might be going on. So this underlying traumatic issue that's bringing about some of this symptomology. So they're addressing more of that underlying issue in working to kind of increase some of those protective factors. And it's been identified that, you know, child trauma is really less stigmatized, although you know, it's unfortunate, but I still see stigmatization with childhood trauma and mental health. So I see it with both. So this has been something that's been very helpful for me to utilize. I've used the Strength and Difficulties Questionnaire. This can be used, so it's a parent report and a teacher report, and so you can use it and you can kind of assess both, and it really goes through 5 scales. It's not super long. It is a little timely, but it's not really bad, and you can really evaluate through both and get more of an accurate perception of what's going on. This is utilized for kids between the ages of 3 and 16. So it's across the board, and it is free domain. So I did provide the website underneath that you can find that at. And you'll share the PowerPoint, right? Okay.
Yeah, I'll be sharing it in the recap.
Okay. So yeah, this has been really beneficial. The other tool that's been really helpful for me is the Children's PTSD Inventory. So this is more of a structured assessment, like it's a structured interview. It's used between the ages of 6 to 18, but it really goes into detail of the event, the reactions, current reactions, the exposure, what some of the reactivity is like now, what it was like then, what it's like now, the increased arousal states. So it's really, this one does cost. So there is a small cost to this one, but it's really helpful. And these are all on the National Child Traumatic Network website. And that's an amazing website. So if you look up in the top corner, these master clinicians, so this is a series in the National Child Traumatic Stress Network. And really they have so many, I don't know, let me see if I can, let me stop sharing this for a minute and see if I can pull up the national. I might have problems with that. I better not. We'll just share this. So if you go onto the website, what you want to do is if you just search the master clinicians, they have tons of different webinars on different areas. So they have anywhere from like traumatic or trauma assessments to the impact of trauma on the early childhood, impact of trauma on the brain, how to address trauma. And so I actually just sent one of them to one of the students that I'm working with because she's given a trauma child and she doesn't have much experience in that area, and she's like, where do I even start? And so it really is a super helpful resource to go into these webinars. I think it's really great. And the middle book, The Whole Child Brain, that's my favorite. So for those of you who have not heard it, like Dan Siegel's like amazing with childhood trauma, and so I really use a whole lot of his techniques like a lot of the time. So this is a great book to reference to as well. It talks about not only the impact on the brain, but it also talks about different strategies you can help parents to understand how to address some trauma that children have experienced. And then SAMHSA, of course, has the trauma-informed care for behavioral services. Now, this is more of an outline of trauma, how individuals are impacted, and how you might want your facility to look like if you're going into trauma-informed care. And so that can have a huge impact on children, especially if they have had medical trauma. I have kids that I've worked with that have had medical trauma, and they still have a difficult time even walking into our building. Our building is a little intense sometimes. We have security guards and metal detectors, and it's still next to a medical facility. So there's the helicopter that comes over, and that can be re-traumatizing for kids who have experienced medical trauma. And so I have some of my kids who have experienced medical trauma have a hard time just coming into this building. So telehealth has been super helpful for that. I actually had one kid come back because they don't have to come into the building anymore. It can be difficult, and it's difficult to tease it out. And when diagnosing, that can be a difficult piece, especially because a lot of the algorithms overlap one another anyways. And so then you add trauma into the mix, and it's like, whoa, sometimes I look at it and I'm like, I have no clue what the diagnosis is. But then, you know, utilizing tools can be really helpful. You know, that table and utilizing assessments, bouncing it off of a mentor or peer, like totally helpful. I think we all get into those situations, but just taking that into consideration of the impact of trauma. That's all I have. Anybody have any questions? I don't know if Lauren's on here, if she wants to add anything. I didn't see her yet, so she might be still in another, I know she had another meeting.
I saw she had hopped on briefly. Let me see. But thank you so much, Amanda. That was awesome. And like you mentioned, I'll make sure to attach Amanda's PowerPoint in the recap email for you all to have. Lots of great resources in there. Looks like Dr. Swagger sort of had to jump off here. I did see her briefly earlier, so she may be logging back on shortly. But in the meantime, were there any comments, questions, thoughts? Dr. Lillard, I see you unmuted.
Amanda, that questionnaire, I missed it. Strengths and something else. How does it compare to the CBCL?
So it's more trauma focused. So it kind of looks at, and it looks at the 5 different areas. So it's not only looking at behaviors, but it's looking at like emotional responses as well. And so it kind of explores it a little more in depth than behaviors. Let me see. It was the strengths and difficulties questionnaire. Yeah, so it looks at, I mean, the CBCL kind of really looks at behaviors. It briefly hits on like peer interaction, but this kind of goes into a little more detail with peer interaction, emotional symptoms, and then like pro-social behaviors. So the CBCL doesn't really cover a whole lot of like pro-social behaviors. And so it kind of lets you look at strengths and weaknesses. A good question.
Carmen, I saw you had unmuted as well.
Hi. Yeah, when we talk about the ACEs study, we really try and focus too on just that resilience factor that people have, because once you find out you have a high score, then what? And so that's kind of one of the things that we talk about, and we try and focus on, like, what's your next step after you find out that score is pretty high, but there are things you can do to be more resilient, even with a high score.
Yeah, absolutely. I think that that's a perfect approach, right? And the CDC identifies those 5 areas of resiliency to really help parents kind of explore, right? So they talk about concrete resources to help parents build resiliency, parenting tips, parenting strategies, learning social emotional growth and development. They talk about, you know, parents identifying their own mental health, and receiving services for that. So yeah, absolutely, you're right. It can have a really negative response. I do a lot of work with our MAT program and working with pregnant moms and parenting pieces. And when we talk about the ACEs, you know, and especially when they get their ACE scores, right, then they're like, oh, like, and they already hold that guilt for either having used while the baby was in utero or, you know, being on medication. And so they already hold a whole lot of that guilt. And they have some of the similar responses. And we totally focus on the resiliency piece, right? How they've overcome major pieces. And that's that strength-based approach. And so that's when you're looking at really focusing on those strengths so that you can increase those protective factors to overcome the risk factors that they already have or have had. And so you're absolutely right. You definitely want to help them focus on those protective factors that they have or that they can increase. And that's the great piece, right? Because kids are super resilient and there's tons of neuroplasticity in the brain that reformulates. And so we can always talk about how that can happen with kids and you know, especially in recovery too. So you're building more neural pathways in recovery, and we can talk about how they're doing that together even with their children.
Thank you, Amanda. Dr. Swagger, I saw you hopped back on there. Was there anything you wanted to say as well? I think you might be muted.
Hi guys, I I admittedly am having 3 screens running at the moment, so I have been slightly distractible. I listened and agreed with everything Amanda was saying as I heard it, but if there's any questions I could answer, I will happily do that. I missed it if there was a question.
Thank you. It's impressive, your multitasking abilities.
Well, I'm not sure how successful I'm being, but.
Well, it's good to have you regardless. So, were there any other comments, questions, thoughts about Amanda's didactic, or questions for Amanda?
Hi. What are some of those protective factors, if you could summarize them?
So let me see. I was thinking that I had another slide pulled up with the protective factors. Oh, I do. Hold on. Let me share my screen. I have like 5 windows open, so I have to navigate myself back. So this is a didactic that I'm doing later on managing difficult behaviors, but you can see that these are the protective factors that build resiliency, right? The concrete resources like we talked about. So that's housing, food availability, transportation, which is huge in our area, right? And sometimes when you look at all of these protective factors, it can be overwhelming. So with patients, I take very small steps, and some of the moms that I work with, getting their license back is huge, and that's huge for independence, and that's a huge protective factor for them because it's transportation. So we might take time and I might show them study strategies on how to study for your test, right? They're overcoming that, and they're working together. And now, when I work with some of these moms, I work with them in a group setting, so that's nice because they can get support from other group members as well, and so that can be a piece that they get involved with. But those concrete resources, if we can not only help link them, but help them navigate through, because those hoops can be difficult to jump through, and so help them navigate through that. If you have a case manager in your facility, that can help them do that and walk them through some of those steps, filling out some of those forms. I mean, those are big, and it's almost like these are tools that they need in their tool belt, but they don't always know how to use it, right? So if you give someone, I just said this in a talk I had earlier this week, if you give somebody a hammer, they should know how to use it, right? Even if they've never used it before. But if we don't show them the right way to use it, there's a chance they could get hurt or they can give up, right? So we want to show them how to use it. And so sometimes it's embarrassing. I know for me, if I was given a hammer the first time, I wouldn't want to ask somebody how to use it. Like, you should know how to use a hammer. And so, it's the same thing with some of these protective factors when you're working with parents. They don't want to admit that they don't know how to fill out a form or respond to some of this. So really just helping them know how to use it. Strengthening their support system. So helping to build relationships within their communities, stop from isolating. I know especially in the recovery population, those moms tend to isolate a whole lot, which can be very dangerous for them. And so we talk about linking to healthy support systems, really sitting down. I have a lot of moms that come into and they say, I don't have anybody. I don't know anybody. Nobody can help me. I don't have anybody. So really they do. And so sitting down with them and doing an eco map, or kind of identifying who's in their system, who's around you, who do you have around you, whether they're good or negative influences. And so we kind of explore that, and then we build those protective factors because they can at least identify one person out of that usually. And so we start to build those protective factors. In strengthening their support systems, we also link them to building their relationship with schools. Schools can be very intimidating to talk to sometimes, and parents shut down a whole lot, but we talk about ways to link them to that. Sometimes we've helped facilitate that. Also, we talk about when you're talking about strengthening their support systems, I had some moms do, and in my group too, I had them do an activity where they had to go visit their local library. And so when I had moms do that, they came back with so many resources. They're like, I didn't even know we had a library, or I didn't know the library offered all of this. And so, sometimes in more rural West Virginia, they're not aware of where the library is, or that it offers so many nice programs for kids. And so linking them to some of those support systems that will help engage them back into the community. That's a protective factor. That's a protective factor to overcome trauma. Parenting education tips and courses for caregivers. A lot of the times caregivers, you know, especially when you're working with foster parents or adopted parents who had just taken on kids who have some complex trauma, they're not really sure how to manage it or how impactful early childhood trauma is throughout their lives. And so really just providing some of that education and support is really important. I always say we don't have enough support groups in West Virginia. And, you know, it's my dream to always start one, but then, you know, other projects take over. But that's really what I want to do is like parent support groups. I think when I retire, that's what I'm going to do, like just do parent support groups. Because it's difficult being a parent, and it's such a protective factor when parents are able to relate, especially parents who are struggling with kids who have experienced trauma, right? Some of the behaviors and some of the symptoms can be very frustrating. And understanding a child's social, emotional, and cognitive capacities. And we've talked about this before, and we talked about how this is like practical magic. So helping parents identify where their child's falling as far as their development, and it could be very different than their chronological age. And when you meet them where their development is and meet them where they're at and work with them there, it's magical what can happen after that. And so using some of that practical magic and meeting them there. So those are those protective factors.
That was awesome. Thank you.
Thank you. That was
You're
great.
welcome.
Any other questions, comments?
I was just going to comment that for anybody who is a clinician and is interested, there's some helpful resources on childhood dissociative experiences scales that are available, and same for adolescents. So if that's something that you feel may be impacting your clients, that's available online as well, and some information of how to utilize them. And there's some wonderful books out there to help kids understand too if they're having dissociative experiences.
Yeah. Thank you for sharing that. Maybe you can share those books with us too.
Absolutely. Anna Gomez has been writing books. She utilizes EMDR for her practice, and she's been writing books on helping kids and adolescents understand.
Thank you.
Thank you for sharing that. Anything you'd like me to share in the recap email that would be helpful for everyone as far as resources go, just shoot me an email. I'll make sure to have it included as well.